Welcome to British Biomedicine Institute. Today Dr. Pramod Khatri, is going to represent a simple topic named as study design in epidemiology. So in this topic, I will be covering epidemiological research, classifications of design, qualitative methods, quantitative methods, and the choice of design. So under epidemiological research, basically the lab research, it applies the knowledge of the basic science toward the development of procedures and strategies in order to prevent, control, or understand mechanisms which are health related. In epidemic investigations, basically, we study the outbreak in the local populations in order to identify the agents, transmissions, modes, and possible control measures. Whereas in population-based or field research, we study the distribution, determinants, control measures of the health-related phenomena in a chosen populations, followed by the applications of the suitable biostatistical techniques which may allow generalization of the result. Data collection method basically consists of either your primary or your secondary. So under primary, where the investigator is the first to collect the data, the sources include medical examination, interviews, observation, etc. Whereas the main advantage is that there are less measurement error, and it suit the objective of the study better. And the main disadvantage is that it is costly and may not be feasible for everyone. Whereas in the secondary data, where the data is being collected by the others for the purpose that those of like in the current studies, it is main suitable for individual records like medical employments, or group data like census data or vital statistics. So the basic definition of the study design is that a study design is a specific plan or a protocol for conducting the study which allow the principal investigator to translate the conceptual hypothesis into operational one. Types. So basically quantitative and qualitative, and quantitative is been further redivided into experiments and observations, which can be basic, hybrid, or incomplete. So under qualitative design, basically there will be a comparison between qualitative versus quantitative. Qualitative helps in better understanding. We can use interviews or observations data. We can discover the framework. Textual can be used. Theory are generated. Quality of informant more important than the sample size. Subjective, sometimes subjectives. We get embedded in knowledge or information, and the model of analysis means fidelity to text or word of the interviews. Whereas under quantitative, basically there is a prediction of the data, or with the help of surveys or questionnaires, or we can use in the existing frameworks, numerical data is collected, or we can say theory testing is done. Sample size is the main data, objective and public data has been collected, and the model of analysis is basically parametric and non-parametric. So under qualitative research techniques, we will be conducting a participant observations, like these are the basically field notes, or we can conduct interviews, or we can focus on group discussions with the key informantants, or we can use video or text or image analysis like your documentation or media data. Survey can be conducted, or user testing can also be conducted. It involves like your observing skills, conversing skills, participation skills, and interpreting skills. Qualitative techniques can be consist of your participant observations. Basically here there will be a gain insight into understanding of cultural pattern to determine what necessary or needed in tool development, or we can say complementary to interviewer. Whereas in the interview, or we can say focus group with stakeholders, we are going to explore how tools are used or could be used in no voice program courses, or we can also gain insight in the meaning of tools for students for the learning of the new program. Data analysis. Basically, themes arising from data would provide insight into the current learning to program issues and see what is important to students, to teachers, and to the administrator. Whereas under survey, basically it is useful for verifying results on a large scale. And user testing is basically useful in triangulating the results. And the rigor in the qualitative research is dependability. Second point, credibility. Third point, transferability. And fourth point, conformability. Under qualitative design, basically, we will be taking care for the observational data studies that do not involve any intervention or experiments. And under experimental studies, which entail manipulation of clinical study factors like the exposures and randomization of subjects to treatment like exposure group. Observational designs includes selected units like your individual or the groups, or study populations like your cross-sectional studies or longitudinal studies, data collection timings like your prospectively, retrospectively, or combination, and data collection types are basically primary or secondary. Study population. Basically, under cross-sectional studies where only one set of observation is being collected for every unit in the clinical study at a certain point of a time, disregarding the length or the time of the study as a whole. Whereas under longitudinal, where two or more set of the observations are collected for every unit in the clinical study. For example, follow-up is involved in order to allow monitoring of a certain population like cohort studies or over a specific period of a time. Such conditions are at risk or they can be disease-free at the start of the clinical study. So under the classification of the observational designs, like your exploratory, basically they are used when the state of knowledge about the phenomena is poor, or it is of small scale or of limited duration. Whereas descriptive designs are used to formulate a certain hypothesis like your small or large scales. Example, your case studies or cross-sectional studies. Whereas analytical studies designs are basically carried out to use for a test hypothesis, or they can be either basically they can be small or large scale. For example, case control, cross-sectional, or cohort studies. Under preliminary, we will be comparing, or we can get data from the case reports and case series, whereas in the basic there will be cross-sectional, case control, cohort like your prospective and retrospective. Hybrid model, two or more of the above nested case control within the cohort are available, whereas in the incomplete like your ecological or PMR design are being used, and in others like your we can use repeated case, crossover, or migrant or twin design, etc. So under case series, or you can say clinical case series, basically they are used in coherent or consecutive set of cases of a particular disease, or they are similar problems which derive from either the practice of one or more health care professionals or a defined healthcare settings like your hospitals or family practice. A case series is effectively a large, or we can say effectively is a register of a cases. We can also use, or we can also analyze case together to learn about the particular disease. Clinical case studies are of value in epidemiological studies for studying the signs and symptoms. Second point, creating case definitions. Third point, clinical education and audit and research. When a clinical case series is complete for a defined geographical area for which the population is known, it is effectively a population-based case series which consists of population registers of the cases. And under epidemiology, the most important case series are the registers of serious disease or usually deaths. and of the health service utilization, like your total hospital administrations or admissions, or usually it is compiled for the administrative or legal reasons. So under natural history and spectrum, by delving into the past circumstances of these patients, including examination of past medical records, and by continuing to observe them to the death, or we can say necropsy, as appropriate, health professionals, they can build up a picture of natural history of a disease. Population case series is basically a systematic extension of this series, but it involves additional cases like those dying without being seen by the clinician or by the doctor or by the physician. Add breadth to the understanding of the spectrum and natural history of the disease. So full epidemiology use of the case series data need formulation on the population in order to permit calculation of the rates. The key to understanding the distribution of disease in the population and to the study of the variations over time between the place and by the population's characteristics. And under the case series, we can provide the key to sound cases control and cohort studies and the trial. The design of case series is conceptually simple, and we can also define the disease or a health problem which we will be studying, or we can set up a system for capturing data on the health status or related factors on a consecutive cases. So under the requirement of interpretation, basically to make a sense of case series data, the key requirement are diagnosis or case definitions for mortality or cause of the death. Second point, the date when the disease or death has occurred, time period, the place where the person lived or worked, etc. Place, the characteristic of a person, opportunity to collect additional data for medical records, possibly for electronic data linkage or in the person directly. The size and the characteristics of the population who are at risk is also been taken into the account. The additional data includes case series data. It can be linked in other health data, either in the past or in the future. Example, mortality data can be linked with hospital admissions, including at birth or at childhood, cancer registries or other records, in order to obtain information on the exposure and the causes and disease. The cases can also be contacted for additional clinical information. Now, the type of actions may turn a case series design into a cohort design. So the strengths are: population case series permit two arguably unique form of epidemiological analysis and insight. The point a true national or even international population perspective of the disease, and the disease pattern can be related to aspect of society or the environment that affect the population but have no sensible measures at the individual level. Example, ozone concentration at ground level and the thickness of ozone layer at the earth atmosphere. So under community health studies or surveys, basically the characteristics are to detect point prevalence, relative conditions, and allow for stratification. Whereas the main merits are: it is a feasible, quick, economic, slow study of several disease or exposures, and useful for estimation of population's burden, health planning, and priority setting of health problems. And the limitations are: it is a temporal ambiguity or cannot determine whether the exposed preceded the outcome, and the possible major errors, or it is not suitable for rare conditions, and it can create, or it is liable to survive bias. And the effective measure is it can help in calculation of odd ratio. So case control studies, the main characteristics are: it helps in two source populations, assumptions that none cases are representative of the source population of the causes, merits: least expensive, least time consuming, suitable to study rare disease, limitations are not suitable for rare exposures, liable to selection bias or recall bias, and not suitable for calculation of frequency measures. And the effective measure is odd ratio. Cohort study. The main characteristics are follow-up period or prospective or retrospective data can be collected. Merits are non-temporal ambiguity. Several outcomes could be studied at the same time and suitable for incidence estimation. The main limitations of this are they are expensive, time consuming, inefficient for rare disease and may not be feasible. And the effective measure is risk ratio, or we can say relative risk. So ecological studies basically are those when the exposure data which is related to a place, or we can say hardness of a water, which could be collected on individuals and they are correlated with health data which is collected on the individuals but summarized by placed conceptually. The ecological component in this kind of study is an issue of data analysis and not on the study design. And the relationship between the exposure and the outcome at individual level are basically missing, or we can say they show a incomplete design. So under ecological studies, the cross-sectional studies or case control studies or cohort studies and trial related study could also be analyzed in relations to an ecological variables and such unit of analysis. Most ecological analyses are based on population case series, and the ecological analyses are suitable for ecological fallacy. So under ecological fallacy, imagine a study in the world of CAD, coronary artery disease, in capital city of the world related to the rate of average of income. Suppose within the city study, we want to explore the CAD is higher in rich city than in the poor ones. We might predict that such a finding that being rich, it can increase the risk of heart disease. Whereas in the industrial world, the opposite is in the case. With poor city, within the cities such as London, Washington, Stockholm, poor people have higher CHD, congestive heart disease, than the rich ones. And the ecological fallacy is usually interpreted as a major weakness of ecological analysis. And under ecological analysis, however, we inform us about the forces which act on the whole population. So under experimental design, basically a study in which the population is selected for a planned trial of a regime whose effects are measured by comparing the outcome of the regime in the experimental group versus the outcome of another regime in the control group. Such designs are differentiated from the observational design by the fact that there is a manipulation of the study factor like your exposures or randomization, or we can say random allocation of the patient treatment in the exposed group. So why it is performed? So basically it provides a strong evidence of the effect, or we can say outcome, which is compared to the observational designs with maximum confidence and assurance. It also yields high valid results, and as a variation is minimized and bias is controlled. We can also determine whether the experimental design are safe, effective under controlled environment as opposed by the natural settings in observations design, especially with the margin of expected benefit is doubtful or it is narrow, if suppose it is between 10 to 30%. So the types of clinical trials are basically, they can either be controlled or not controlled, and if they are controlled then they will be randomized, or if they are not randomized, and if they are randomized then they will be either blinded or not blinded. So the main advantage of randomized clinical trials is that the gold standard of research design, and thus they provide the most convincing evidence of relationship between the exposure and the effect. For example, the trial of hormone replacement therapy in menopausal women has no protection for heart disease, contraindicating findings of prior observational studies. The main advantage is that it provides the best evidence study design, no inclusion bias, or we can use blinding, controlling over possible co-founders, and we can use comparable groups, or we can use randomization. The main disadvantage of RCT are large. These are basically large trials and they can affect the statistical power. They have a long-term follow-up, or which can lead to possible loss. Compliance is again a problem. They are expensive. Public health perspective is also be taken care, and there are possible ethical questions. So under the choice of design, it entirely depends upon the research question, research goal, researcher benefits and the values, researcher skills, time and fund. It is also related to the status of existent knowledge, occurrence of disease, duration of latent period, nature and availability of information, and the available resources. So while comparing the study design, we look for theme, ease, timing, maintenance and continuity, cost, ethics, data utilization, main contribution, observer bias, selection bias, and analytical output. So under overlap in the conceptual basis of quantitative study design, basically the cross-sectional studies, they can be repeated. And if the same sample is being studied for a second time, or it is a follow-up, the original cross study now becomes a cohort study. If during a cohort study, the possibly in a subgroup, the investigator impose a intervention and under the control study, they also give birth to case control studies using incidence cases, or we can say nested case control studies. And cases in case series, particularly a population based one, may be now the starting point for case control studies or a trial. Not every epidemiological study fit neatly into one of the basic design. Now comes the conclusion. Quantitative designs are complementary to quantitative design, and as these are important in studying the social determinant of health problems. Quantitative design have a common goal to understand the frequency and cause of health related phenomena, and we can also seek cause starting by describing associations between exposure or cause and outcome. The case series is a cohort set of cases of a particular disease or a similar problem. The cases are compared with reference group. We have a case control study. In a population study, at a specific time and a place, a cross-sectional, the primary output is the prevalence data, though association between the risk factor and the disease can be generated. In cross-sectional studies, we are looking for both exposure and outcome. In case control studies, we know the outcome, looking for the exposure. In cohort study, we know the outcome, follow up looking for the outcome of that question. So if the population is a control sectional survey, is followed up measuring both health problems, this design is known as cohort study. If the population of such study are at baseline divided into two groups and the investigator impose a health intervention upon one of the group, that the design is that of that group. Study based on aggregated data are commonly referred to as ecological studies. Most ecological studies are the mode of analysis rather than the design. Interpretation and the application of data are easier when the study between the population observed and the target population are easily understood. Randomized clinical trials represent the gold standard of research design, and they thus provide the most convincing evidence of relationship between exposure and the effect. So this is all about the presentation. I hope you have gained a lot of clinical information through this presentation. Please like, share, subscribe our YouTube channel named as British Biomedicine Institute. Good luck. Goodbye.